presenting a new series Medically Verbal where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 6: Chief Complaint. A 30-year-old female presents to the emergency department with severe abdominal pain. History of present illness. The patient reports a sudden onset of severe, crampy abdominal pain that started 4 hours ago. The pain is located in the lower abdomen and is associated with nausea, vomiting, and a fever. She also mentions experiencing diarrhea over the past 2 days, which has been watery and frequent. She denies any recent travel, antibiotic use, or known contacts. Past medical history says irritable bowel syndrome. She is currently on known medications, doesn't smoke, drinks alcohol occasionally, and works as an office manager. Family doesn't have a history of gastrointestinal diseases. Her BP is 110, systolic 70, diastolic, heart rate 95, respiratory rate 18, temperature 38 degrees Celsius, and SpO2 98%. She is appearing uncomfortable and in moderate distress. She has a soft abdomen, but it's tender in the lower quadrants, and there is no rebounding tenderness or guarding. Bowel sounds are hyperactive. She has no masses in the rectal area and no gross blood, but the stool is watery. Her extremities doesn't have edema and the pulses are equal. Initial differential diagnosis: acute gastroenteritis, appendicitis, pelvic inflammatory disease, inflammatory bowel disease flare, ectopic pregnancy. Based on this presentation, what do you think is the most likely diagnosis, and what further investigations or management steps would you consider? If you're thinking inflammatory bowel disease, currently facing diarrhea, nausea, and fever, it is normal with the IBD flare. Adding up the history of having inflammatory bowel syndrome, sometimes it can coexist with IBD. So what's the first thing that we should do? He's already lost a lot of water and electrolytes due to diarrhea. So we'll try to get hydrated by starting on IV fluids. And at the same time, because she's in a lot of pain, we'll give her analgesics like acetaminophen to manage pain. Now, why aren't we giving morphine in this case? Reason being, morphine is a very powerful, potent painkiller. But at the same time, morphine is a form of opioid. Opioids do relieve pain, but in the case of the GIT, they can suppress the motility. And at the same time, frequent use of opioids can lead to changes in the epithelial lining of the intestine. Morphine is not the choice of analgesic in this case. We'll run blood tests on her, giving a complete blood count to check for the WBC height and even for anemia. At the same time, because there is an inflammation, there are supposed to be some plasma proteins which will be elevated in this case. One of this is the C-reactive protein. So we'll check for the CRP levels. At the same time, we'll check for erythrocyte sedimentation rate. Why ESR? So what happens in inflammation is that ESR often tends to get elevated. When ESR is elevated, we are able to tell that there is inflammation. And why is ESR getting elevated? Because RBCs tend to clump together. So when the RBCs clump, of course, they started weighing more. They settle down very easily, faster, and in a lot more quantity than a normal blood would. And so ESR would be elevated in such cases. We'll see her basic metabolic panel so that we can assess how much of the electrolytes has she actually lost because of the dehydration and diarrhea. At the same time, we'll perform stool tests. We'll do a stool culture to rule out parasitic diseases or any sort of viral diseases. And there is one test called as fecal calprotectin. This test is a non-invasive method to check whether the person is suffering from IBD or IBS. Now, if a person is suffering from inflammation, then this fecal calprotectin is going to be elevated. But if it is irritable bowel disease, the fecal calprotectin normals would be normal. At the same time, once we have done this, we'll go for imaging. We'll perform an abdominal ultrasound or a CT scan to check out for abscess or any sort of fistulas. We'll also do specialized tests. Now, fecal calprotectin was a non-invasive test, but colonoscopy, which is somewhat invasive, but it's done when the patient is stable and the workup suggests IBD. So if we have to confirm it out, we would go for a colonoscopy to also check the severity of the inflammation. Once we have diagnosed it out, we will start the patient on corticosteroids like prednisone so that the inflammation is reduced. We would administer them with aminosalicylates like mesalamine so that we could reduce the severity of the disease. We'll ask them to go for immunosuppressants like azathioprine for long-term management, and we'll ask them to go for biologics. Now, biologics is considered when the patient has not responded to any sort of treatment and the patient's condition is between moderate to severe. Okay, these are usually what they do is basically they block the proteins that cause the inflammation. Okay, so in this way they are blocking the proteins that are causing the inflammation, indirectly helping in healing the intestine. We'll provide them with adequate nutritional support, so with a low residue diet so that the bowel frequency is reduced, and we'll give them with antidiarrheals so that the flares are reduced and the risk of a toxic megacolon is also dialed down. And then we'll ask them to monitor, and then we'll monitor their vital signs and fluid status regularly to see how they're responding to the treatment and ask them for a regular follow-up. Hope you guys liked the case of today. Make sure to take a screenshot so that you can sum it up later, or you can always come back. Thanks for watching. Take care. Bye. Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.